Good afternoon, everyone. It's a pleasure being here, and first of all, I want to appreciate Kyoto University for giving me this opportunity to be here. Okay, good. Well, as a matter of fact, TB, as we know, is one of the top causes of death worldwide, top 10. As mentioned in previous presentation, it's number 9. So, and it's a leading killer of HIV positive patients. This is a serious problem globally and especially in developing countries. And we know very well that the universal approach in concerning TB patients is to promptly get them tested if they come with symptoms, and also promptly get them treated. So, but we know very well, again, I don't know much about most of the, Japan or other developed countries. It is a big problem in developing countries that most of the patients, when they get diagnosed, they don't get on treatment. That's a reality. So, and this phenomenon is called pre-treatment loss to follow-up. I'll explain in a bit what this is all about. So, this flow chart or the diagram here tells us how the pathway that patients usually follow. From when they are sick, they then approach the health facility and they will be diagnosed or symptoms presented to the doctor. The doctor says, okay, you can go to the laboratory for your sputum to be tested. And from there, we expect that they should get to treatment. But this is not the case. So some actually dodge or just slip along the way. So this is what we then term pre-treatment loss to follow-up. So they don't get into treatment. So this is where we are interested in. So global figures of pre-treatment loss to follow-up ranges between 4 and 38%. And the previous study that we did in Cameroon found it to around 17%. And looking at this problem, which we think both WHO and the national TB programs globally have failed to look into, we said it was better for us to look at this intervention, if there are any intervention that could help. So actually we got only one, which was in a proposed model from India. And they wanted to use resident welfare associations that are within some localities where they could work with the NTP to see that patients get treated easily. Apart from that, there's no other study regarding pre-treatment loss to follow-up in the reduction or mitigating this phenomenon. So looking at counseling and phone reminders, we don't have any study yet in decreasing pre-treatment loss to follow-up of TB patients. And again, so we just wanted to evaluate the impact of counseling and phone reminders on the incidence of TB during the causal experimental design. And the second aspect was for us to look at the risk factors for pre-treatment loss to follow-up among these patients from these two regions in Cameroon. So just to explain, this is a post hoc evaluation. Actually, we never planned to look at counseling and phone reminders because these were not our primary objectives of the study. We had two studies. The first cohort, which is here, was done in 2015, and this second one was 2016. So looking at this one, our definition for pre-treatment loss to follow-up, that was if you are diagnosed and you don't get on treatment within 7 days. Some studies have used just a day, some 2 days, some 3 weeks, some 1 month, some even 3 months. But in our study, we decided to use 7 days as the limit. If you don't get on treatment within 1 week, we consider you as you are lost to follow-up before getting on treatment. So that's what we used here. And even this one. This is just an illustration of what we did. It's not a result. And why here, this one did in 2016. From here, at this point, since we did not put a priori that we're going to evaluate counseling and phone reminders here, what we did here was during the informed consent administration, talking to the patient, answering their questions, and telling them that I'm going to call you if you don't get on, if you don't start your treatment early or you don't start your treatment within 7 days. We're going to call you, seeking a consent for participating in the study. This is Cameroon, somewhere in Africa, on the west coast, somewhere there. Then these are two regions that we decided to do the study. I'm sure yesterday we heard about before and after study. We'll be talking about post-experimental study. So this is what we use in this particular study. So we got about 2,200 newly diagnosed patients, all above 20 years. And for the first group, the control group, we had about 1,100, and the other was about similar, 1,100 also, the intervention group. So this was done using 39, about 40 TB diagnostic and treatment units in these two regions of Cameroon. And outcome variable, we're looking at pre-treatment loss to follow up, those who didn't initiate treatment within 7 days post-diagnosis, and the time to treatment. How quicker were these people getting on treatment, even after diagnosis? And just to mention here that we had to seek ethical approval from Cameroon and also from Taiwan. The National Ethics Review Committee, Cameroon, and then NTU, National Taiwan University Hospital, RB. So, looking at the outcome of pre-treatment loss to follow up, which I explained before, we use 7 days as our cutoff. This could be anything, but in this particular study, we use 7 days. So, these are the people who never started treatment. This one, they start treatment within 7 days. The same thing, the second variable that we look at time to treatment, the survival analysis. We have to follow up the patients for up to about 4 weeks to see those who got on treatment and those who did not, or how quickly they got on treatment. So I'll just talk now on method of collection, what we did in collecting data. The first point is the form of getting people recruited to the intervention group. We had to talk to them, and that was in the process of giving their consent. We also administered questionnaire to them. In this period, we collected their phone numbers, and also answered some of their questions. In the previous cohort, this was not done. Nobody had talked to them, nobody said anything to them. So we also informed them that we are going to call them. We're going to maybe up to 3 times. And send SMS, we could send people to them regarding if they don't come to get care within 7 days. We also took data. This is the laboratory book provided by the National TB Program, and this is the treatment book. So we treat data from these registers, and also we measure data together, both from the first cohort and the second, and also cross-link the data between the diagnostic register from here, laboratory, and also the treatment to see who got lost along the way. Because we're interested in these people. Because we know once they are out there, they're not getting treatment, they are infecting other people. So we also were interested in calculating the distance from their home to the DTU, the diagnostic centers. So we had to take the geo codes from the diagnostic center and also from their addresses. So we had already informed them that we're going to call them if they don't start treatment. So we also did that after 7 days. And just to show here, so that's some of the photos that I did while I was in the field, traveling from one hospital to another, quite diverse community, a lot of obstacles on the way. So patients do go through this. So as the PI, I also have to go through all this to get to these centers. So quite treacherous. You can see they're all end roads. You hardly get tarred roads, especially if you are not within the urban facilities or urban areas. That's why places that you get through. So at times it's difficult to get to some of the centers. Quite muddy, rainy, you have to get there. At times I would not even go with a trooper. I have to use my motorcycle. I'm back there with somebody there. As terrible as it can be, patients have to go through this to get to centers. So as the previous speaker was talking about barriers to treatment, that's what the things that we get all the time. So let's look at the analysis. So we did logistic regression to look at some of the risk factors why patients don't really get treatment. Then also look at the survival analysis. And we wanted to look at the effect of the intervention, the calling, tell them I'm going to call you and call them, and also the time trend, whether there was anything involved in treatment loss to follow up. This is exactly the general characteristic that I want to just see whether there was any difference between the two populations. So that was the number of patients, and we had more males in this group, and fewer of them, or less than 30% or less than 25% were living in rural areas. But also, the only problem was that we saw, because we had some difference in the microscopy and extra method of diagnosis, so it was the only difference here, but the rest were all similar. So looking at the logistic regression results, the univariable and the multivariable, we saw that there was a big difference, significant difference between the control group and the intervention group. You can see here, from 17.5 to about 10.6. So close to about 40% in the intervention group. So looking at the two regions that we considered, you see that they were more default, close to 1.5 times more than in the Northwest region, these two regions. And even looking at the urban versus rural areas, more default, close to twice, 2 times compared to the rural areas. Okay, we also use travel time. How long does it take these patients to get to hospital? And also travel distance. We see here that those who live further away from the DTU, the treatment unit, diagnosis and treatment unit from their home, if you live more than 30 kilometers or you spend more than 30 minutes travel from your home to the hospital, more likely that you are going to drop out or get the treatment a bit prolonged, not within the 7 days. So that was actually a significant risk factor. So time to treatment. In the intervention group, however, we found that it was quite significant that those in the intervention group got on treatment before, quite earlier, compared with the control group. And again, this region was somehow getting a bit less quicker to treatment compared to the Northwest. And there was a problem also in the urban areas. People were getting quicker on treatment in private facility compared to public because people, some of them lost trust. And again, those who travel longer to get to the center were more likely not to start treatment on time. More likely to start treatment on time. And those who live further away, travel longer distance to get there. So this is where we try to look at the intervention. What really happened? Was there something specific that happened here? So the intervention here This is the before, and this is the after. So we saw that there was actually a decrease in pre-treatment loss for following this intervention. As a summary of the key findings, we saw there was a significant reduction, close to about 40% reduction in odds of pre-treatment loss follow between these two groups, the control and the intervention group. And there was 30% significant increase in this intervention group in starting treatment compared with the control. And again, travel distance and travel time, if there was longer time, there was increased odds, close to 70% or more in defaulting. So presumably we think counseling of TB patients and phone reminders will have played a significant role in this reduction. And that we try to analyze that using the logistics continuous regression analysis. It was not statistically significant between that, between PRTFU and the intervention and time. So because of the fact that we've not had any particular study that has looked into counseling and phone reminders in reducing pre-treatment loss to follow-up, it might be difficult to discuss this in terms of previous study because there's none. However, the implication is that counseling of TB patients before and after the result is issued and phone calls to remind them to get on treatment could have played a significant role in reducing pre-treatment loss to follow-up. Sorry. And 40% reduction is quite significant, but statistically and also clinically, we want to see patients to get on treatment. We don't want people to stay out there to spread tobacco bacilli. And with a 30% reduction in pre-treatment loss to follow-up, even though it was not as significant, we find this very important, that just talking to people, talking to these TB patients that we're going to call you, and we actually call them, and in places where we could not get them, we had to talk with other people to reach them. That really helped. So we believe that there's a good gap between the control group and the intervention group in terms of the reduction of pre-treatment loss to follow-up. And again, our good strength is that we included over close to 2,200 people in this particular study. Well, in terms of limitations, we'll say that since we could not randomly assign these patients to various groups, we think that this could be something like a pitfall. However, I also believe that there could be some confounding because we actually don't know, because policy, the race didn't really change. So what could have been this reduction, causes reduction in pre-treatment loss to follow-up? In conclusion, I want to say here that implementing counseling and phone call reminders intervention could be a good intervention in reducing pre-treatment loss to follow-up. Even though we could not generalize these findings, but I'm sure it will be able to work very well in developing countries like mine. And with pre-treatment loss to follow-up being a significant problem in Cameroon, even though we don't, most countries we have free treatment. However, we think that there's need for government to look into these issues strictly and see how we can reduce pre-treatment loss to follow-up within the community and the nation. So we try to encourage adequate pre- and post-test counseling for TB patients, because we should not only wait for those who get treatment, then we check whether they're defaulted or not, but we need to check those who don't even start the treatment, who don't even start it. So in some places, some people don't even have cell phones. They don't have electricity. So again, we will try to encourage people to have means that they can be contacted. Though at times we use outreach workers to reach them, but that they should be able to have. Then last but not the least, I think government and telecom companies could collaborate in putting up facilities that could encourage, that could give good coverage of network within the community and even the country. A future direction will be to probably conduct a randomized control trial to really see the effect of counseling and phone reminders in mitigating pre-treatment loss to follow-up. Again, just to say thank you, Kyoto University, for giving me the opportunity to be here. And this study was sponsored by Center for Disease Control Taiwan and NTU College of Public Health. They provided funding for primary data collection in Cameroon. And not the least, I want to thank colleagues at NTU and also colleagues in Cameroon for the support they provided in this study. Thank you very much, everyone.